So we are on live now. We can go.
A very good evening to all of you. I am Hetal Gohil, and it's my privilege to welcome you all for the today's insightful webinar on Resmetirom reverses the MASH. Metabolic dysfunction associated steatohepatitis or MASH is a progressive form of uh, metabolic dysfunction associated steatotic liver disease, and it affects almost 30% of the population globally and approximately 50% of the Indians. It is found that MASH is strongly associated with obesity, diabetes, hypertension, hypothyroidism, and dyslipidemia. Unfortunately, the condition is often asymptomatic in early stages, and making the early detection and treatment, particularly in the fibrotic stage of F2 and F3, critically important to slow down the disease progression and improve patient outcomes. Despite the extensive global research, there was a critical unmet need for the effective therapy of patients who are suffering with MASH and advanced fibrosis. Today, with the availability of Resmetirom, the first US FDA-approved liver-directed oral therapy for non-cirrhotic MASH with moderate to advanced fibrosis, we are entering a new era in the hepatology. Resmetirom selectively targets THR beta receptors, regulates the lipid metabolism, and helps in reversing the MASH. This milestone reinforces our commitment to bringing cutting-edge science closer to society and helping to improve patient outcomes across India. To explore this topic in further detail, it is my great honor to introduce our esteemed speaker of the webinar today, Dr. Pathik Parikh. Dr. Pathik Parikh is a consultant gastroenterologist, endoscopist, and liver transplant physician at Apollo Hospital, Ahmedabad, with over 15 years of experience. He has key interest in managing acute liver failure, NFLT, and portal hypertension. He has been trained in the field of transplant hepatology, immunology, and nationally and internationally. He holds several prestigious fellowships, including fellowship in hepatology from London, fellowship in liver transplant and liver intensive care from London, fellowship in liver radiology and oncology from Japan. Dr. Pathik has 50 plus publications in the indexed medical journal. He has also written 10 plus book chapters, monograph on liver diseases and transplantation. Dr. Pathik has delivered 25 plus presentations at various national and international conferences. He has respected member of esteemed medical societies such as Liver Transplant Society of India, American Society of Study of Liver Disease, Indian National Association for the Study of Liver Disease, and European Association for the Study of Liver. Let me share my slide once again. Just a minute. He has been recognized through several awards. To name a few, Maharashtra University of Health Sciences Merit Certificate Gold Medalist, and he holds first rank in DM Gastroenterology. Young Investor Awards in 2015, the Liver Care Foundation Scholarship for Doctors in 2015 in Nazil, Dr. P. N. Berry Scholarship for Study of Abroad in 2015, Tata Scholarship for the Study Abroad into 2015, NASL GSH International Fellowship for Young Hepatologists in 2019. With the great pleasure, I'm now inviting Dr. Pathik Parikh to lead today's session. Over to you, sir, and I sincerely thank everyone for joining us today. Over to you, sir. Thank you so much.
I hope my slides are visible.
Yes, sir.
So thank you for your kind introduction. So coming to the topic and not wasting any time, we talk about resmetirom. Now, this is a molecule that we are going to have multiple companies coming in soon, but as of now, the official availability in India is not there. So let's understand how this works. So to understand, just a couple of slides on pathophysiology. So whatever we eat, the dietary fats and the excess carbohydrates lead to development of insulin resistance and expansion of adipose tissue. This adipose tissue are a source of free fatty acids. These free fatty acids go to the liver and are broken down by beta oxidation by mitochondria. And some of the free fatty acids are converted to triglycerides and VLDL. As the beta oxidation increases, there is mitochondrial burnout leading to impaired mitochondrial functioning. So overall, this results into increased steatosis. There is increased VLDL as a part of mitochondrial burnout, increased reactive oxygen species, all leading to inflammation and fibrosis. Also, with the more knowledge about the gut microbiota, we all know that the importance of gut microbiome is increasing, and as a result, there is leaky gut. There is development of PAMs, and once the hepatocyte gets damaged, they form dams. This leads to stimulation of Kupffer cells and stellate cells, leading to fibrosis. This further worsens having multi-organ effect. I think the stages of liver disease are well known, but the terminology F0 is no fibrosis, F1 is mild fibrosis, F2 is moderate fibrosis, F3 is advanced fibrosis, and F4 is compensated advanced chronic liver disease. So it is advanced chronic liver disease, and using the term early cirrhosis, early and cirrhosis are actually contradictory, and we should not be using, and we should stay away from using those terms. And this further leads to development of adverse liver outcomes. Use the term as major adverse liver outcomes, MALO. So when we talk about the target population for the treatment, so MASH is in the patients of steatosis when there is ballooning and inflammation that leads to MASH. And then there is development of fibrosis. Now we all know that as the fibrosis worsens, the liver-related outcomes are worse. And this is significantly bad for F2, F3, F4. So these are the populations to be targeted upon where we can try and reverse F2, F3, and F4 if possible fibrosis. And there is a data suggesting that if there is a regression of mass fibrosis, there is improved clinical outcomes. So there is lower outcomes, lower liver-related outcomes in patients if we are able to reverse mass fibrosis. And this is significantly better in the patients responding to treatment. Now, we all know that there is a vicious cycle of metabolic syndrome and steatohepatitis or MASLD. So type 2 diabetes and metabolic syndrome leads to 2.2 times increased risk of development of MASLD, which in turn increases the risk 2 to 6 times of development of worsening of diabetes. Both of these conditions can lead to increased cardiovascular mortality, increased renal dysfunctions, and then themselves leading to liver-related outcomes. So that's why reversing the fibrosis is the key to development treatment for MASLD. So when we talk about treatment, it is liver specific and overall systemic therapy. So when we talk about non-liver specific treatment, it is treating the comorbidities better, treating the obesity status better, and tackling the dietary and other cofactors. for the treatment of MASLD, the drugs available, I think GLP-RAs and SGLT2 inhibitors, the anti-diabetic agents are the talk in itself, but they are upcoming agents which are being discussed now left, right, and center. The thyroid hormone receptor, which we are going to talk today, how it is affecting us overall. The PPAR agonist, I think we are all using PPAR agonist for now so many years, and we are quite confident in using them. The FXR agonist, which we are very much disappointed overall, and the new upcoming agents, which may be considered for a combination therapy, are the FGF21 and the FGF19. I would not go into the details of each of the drugs, but I think all of us have been using these agents and quite versed how this function acts. So we'll concentrate on the thyroid hormone receptor agonist, and that is resmetirom today. So importance of thyroid hormones. So if we all know that it is important for energy and metabolic homeostasis. It has a role in insulin sensitivity and hepatic gluconeogenesis as well as lipogenesis. So as a part of normal physiology, 80% of the hormone secreted by thyroid gland is inactive in T4 form. This T4 forms by thyroid gets into the liver and deioninated into T3. This DIO1 leaded formation of T3 is the major substrate for THRB and that is responsible for majority of the actions. However, in cases with dysfunction, thyroid dysfunction, it gets deionated by DIO3 and gets converted to RT3, which is less effective. Coming to the receptors, thyroid hormone receptors are located in multiple organs, but thyroid hormone beta is specifically located in liver and kidney, while thyroid hormone alpha is located on heart as well as on the bones. So when we talk about thyroid hormone receptor beta agonist, it is specifically acting on the liver and not on other organs majoritarily. Now, I think our group 10 years back published that there is some association of hypothyroidism and in NAFLD, and that has been repeatedly over multiple last 10 years. Multiple publications have shown correlation between hypothyroidism and steatohepatitis. And this is associated with poor overall outcomes, with poor worst mortality rates, and that is more subjected to cardiovascular mortality in patients of hypothyroidism. So low intrahepatic thyroid hormone is responsible for development of MASLD. So in patients of intrahepatic hypothyroidism, thyroid hormone receptor beta analogs can form a substrate for T3 and can stimulate a similar form. So in patients with intrahepatic hypothyroidism, RT3 is more, and when we give a THR beta agonist, the routine pathway is stimulated, leading to the benefit, which we would be discussing in next few slides. So let's talk about resmetirom, how it works. It's an oral thyroid hormone receptor beta agonist. So intrahepatic hypothyroidism is responsible for worse outcomes, and to counter this intrahepatic hypothyroidism, there is an oral thyroid hormone receptor beta agonist, and that is resmetirom. It got US FDA approved last year for management of non-cirrhotic MSLD with moderate to advanced fibrosis, that is mainly F2, F3 fibrosis. And it has received conditional marketing authorization in this year for treatment of MASH with advanced fibrosis from the European Society. It can be taken with or without food, and there are different dosages are there, which we would discuss in the next slide. So there are multiple trials for the use of resmetirom, and after more than 1,500 patients receiving 100 milligrams and more than 2,000 patients receiving 80 plus milligram of tablet, it received an accelerated approval. So the current approved indication is in addition to the lifestyle modifications in patient with MASLD with F2, F3 fibrosis, and it is not recommended once the patient develops decompensated liver cirrhosis. The dose is based on the weight. So if you are more than 100 kgs, then the 100 milligram once daily is the dose. If less than 100 milligrams, then it is 80 milligrams. Now, if the patient is taking CYP2C8 inhibitors, especially clopidogrel, then you need to reduce the dose to 60 and 80 milligrams based on the weight. So how it is likely to act? I think that we all know that intrahepatic hypothyroidism leads to mitochondrial dysfunction and overall lipid buildup and worsening fibrosis and inflammation. So when we give a thyroid hormone receptor beta agonist, it leads to a modulation of the expression of the genes that improve the lipid metabolism and overall mitochondrial function. And this resmetirom has 85.4% of activity to the natural T3 hormone. So it nearly reaches the functioning of a natural T3 hormone in the liver because it works only on the beta agonist. So if you talk about MASLD, it enhances the uptake of free fatty acids, it promotes cholesterol breakdown, it increases fatty acid oxidation, it decreases de novo lipogenesis, improves insulin sensitivity as a mechanism of action. Pharmacokinetics, it is mainly excreted in the feces, and the half-life is 4.5 hours. The contraindication, it is contraindicated in pregnant and lactating women, pediatric population, strong CYP2C8 inhibitors like gemfibrocil, end-stage liver disease and end-stage renal disease. Anybody with active thyroid disease, you should not be taking, or active alcohol consumption, it is not to be taken. Special precautions for patients with some gallstones because it can precipitate acute cholecystitis. So in symptomatic gallstone condition, it is not to be given. Now, this is very important that it leads to initial, for the first 4 weeks, some rise in enzymes. And if you are not monitoring it, you may miss it. An early rise in enzymes should be watched for, but the treatment should not be stopped within the 4 weeks, saying that the liver, it is causing rise in enzymes. As discussed, it may cause gallbladder-related complications and drug interactions. Renal end-stage renal disease, end-stage liver disease, it should not be used, especially decompensated cirrhosis. Pregnancy and lactation, we don't have data, and so it should not be used. Pediatric, geriatric population, again, above 65 years of age, more side effects are expected, and so we should be cautious in these populations as well. Some important part of drug interactions, I think, as I mentioned, if the patient is of IHD on taking clopidogrel, we need to reduce the dose. And if the patient is taking cyclosporin or tacrolimus, the combination can be causing more side effects. So in post-liver transplant patients, if the patient is on CNIs, we need to be cautious and avoid using these drugs. If the patient is on high dose of statins, then with resmetirom, it may cause toxicity of these agents and may lead to myotoxicity. Adverse event of the drug per se, not significant, not major life-threatening, but it may cause diarrhea, which may last for a period of 2 to 3 weeks, nausea, vomiting, constipation, abdominal pain, pruritus, and dizziness. But there was no serious drug-related treatment emergent adverse events reported in these patients. So if you look at the European society guidelines, so if you are targeting diabetes, I think GLPs and the SGLTs are super effective. For obesity, again, GLP-RAs. But if you're targeting specifically liver-related, MASH-related treatment for F2, F3 fibrosis, resmetirom is the agent of choice. If you are giving this agent, using this agent at baseline, we need to assess thyroid function, lipid profile besides the liver function test, and that needs to be repeated on a quarterly interval. And on a yearly interval, we need to assess non-invasive liver disease assessment testing, as well as, if possible, MRI PDFF if available for reduction in the fat proportion. If we are giving this agent and if there is response, we need to continue. How do you assess response? There should be improvement of vibration control transient elastography of more than 25% and MR elastography of more than 20% from the baseline. And there should be normalization or significant improvement in liver enzymes for us to continue the agents. But we should stay cautious in not taking this decision at 4 weeks. So this is about the agents. Now getting into the trial portion of it, why these agents got approval. So Resmetirom, the phase 3 randomized control trial published in NEGM last year. Around 966 patients were randomly assigned to 1:1 ratio, and the endpoints were NASH resolution and improvement in fibrosis. So anybody with a significant amount of steatosis, they were into 1:1 ratio of 80,000 or 80,100 and placebo. And if you look at percentage of patients getting a NASH resolution or intention to treat analysis at 52 weeks, which was significantly higher in resmetirom group as compared to placebo, and same with fibrosis improvement. There was key secondary endpoint was LDL improvement. So LDL was also significantly reduced in this patient, thereby reducing the risk for factors for cardiovascular mortality. So resmetirom not only improves liver, but also is expected to improve cardiovascular mortality. And those patients who, in addition to using resmetirom, were able to lose more than 5% weight, there were more than 50% patients with NASH resolution, and nearly 40% patients with fibrosis improvement in patients if they are able to reduce weight in addition to using the agent. So at 24 and 52 weeks, there were additional advantages of the reduction in triglycerides, apolipoproteins. There were reduction in liver enzymes, and there was stiffness, VCT and MRE improvement in patients of using resmetirom at 52 weeks. Looking at adverse event, nearly 10 to 12% had some adverse events, and diarrhea and nausea were the most frequent side effects, and nothing significant. So if we look at the predictability of the response, so if at 12 weeks, if there is a response to resmetirom and there is improvement in MRI-PDFF, we can predict that at 36 weeks, there is going to be MASH resolution as shown by the study. So MRI-PDFF, if you repeat at 12 weeks and it has shown improvement in hepatic fat, then we expect and we can counsel the patients that at 36 weeks, there is going to be MASH resolution significantly. If you look at the parameters, there is sustained improvement in biomarkers while using this agent. So if the patients were continued beyond 1 year, then there was persistent and subsequent improvement in MRI-PDFF as well as apolipoproteins, and improvement was sustained in the fibroscan as well. Now, this agent has also been tried in patients with cirrhosis, but compensated cirrhosis. So compensated cirrhosis was F4 fibrosis or non-invasive clinical assessment. If the patient has cirrhosis, then this agent has been tried, but the requisite for inclusion was platelet count should be above 70,000, and there should be no previous history of decompensation. So if you look at 1 year and 2 year, in overall population, there was significant improvement in the CSPH, and the patients did from 50 to 70 patients had now absence of CSPH if they were started with resmetirom over 2 years for patients with compensated cirrhosis. If the platelets were less than 100,000, so then the improvement at year 2 was significantly higher when using in patients with clinical significant portal hypertension while using resmetirom, which was also evident but not as clinically evident in patients with less thrombocytopenia. If you look at the biomarker in patients with low platelets and more than 100 platelets, there was at 2 years significant restoration of MRI-PDFF as well as fibroscan, and there was reduction in splenic volume. But if there is a treatment interruption, there is a worsening of these numbers as well. And when we reintroduce resmetirom, the response comes back again. It may not be directly related to improvement in fibrosis, but improvement in inflammation. as expected, if there is reduction in fat, if there is reduction in fibrosis, then the quality of life is expected to improve with the use of resmetirom. Coming to safety, I think there is some concern about nausea and diarrhea, but not significant different serious adverse event as compared to placebo in these patients. And even if there is diarrhea, it does settle down in 2 to 3 weeks after continuing the agent. Some serious adverse events included development of hypothyroidism and jaundice and some autoimmune hepatitis. I have already shown this slide that you need to assess the response to resmetirom on a quarterly basis. And if there is no improvement in fibroscan or no improvement in liver enzymes on a quarterly basis, we need to reevaluate whether we need to continue the agent or not. Now, the important question, whether we should select semaglutide or resmetirom in patients with MASH and fibrosis. So this study, network meta-analysis, looked at this outcomes, and what they looked at was enzymes, NASH resolution, fibrosis improvement, improvement in MRI, PDFF, as well as fat resolution, and side effect safety profile was looked between the two agents. So as per this recently published data, NAS resolution, fibrosis improvement, as well as MRI PDFF, so hepatocyte changes were much more evident in patients of resmetirom as compared to semaglutide. More than 30% fat resolution was also significantly better with resmetirom as compared to semaglutide, and enzymes better with resmetirom as compared to semaglutide. Although this study found that there was some treatment-related adverse event and discontinuation with resmetirom, and we should be monitoring patients on resmetirom. So higher efficacy in resolving MASH, improving fibrosis, and reducing liver fat as compared to semaglutide. But semaglutide definitely has a benefit in obesity reduction and in morbidly obese patient with more than 35 BMI. With this measure or any other risk factor, we should consider semaglutide as it has added advantage for weight loss. Coming to saroglitazar versus resmetirom, I think we all have much experience with saroglitazar, and we are quite confident in using saroglitazar in patients with hypertriglyceridemia, and it does work on triglycerides, and it is approved by DCGI and it is recommended by INASL guidelines. While on the contrary, resmetirom is likely to be available in India. It is US FDA approved. It has a much more Western literature supporting the use for it. It does reduce LDL and expected to improve cardiovascular mortality as well. And there is significant fat reduction and fibrosis and histological response, which is proven by multi-center studies with resmetirom. So resmetirom has robust Western data. Saroglitazar, although approved by India, has our own personal experience of using the agent. So when do you use resmetirom? So if you're looking for a liver-specific agent and patient has F2, F3 fibrosis, so fibroscan between, I would say 8 to 14, and even a compensated cirrhosis, you can consider using resmetirom, although approved for F2, F3 fibrosis. And patient we should not be using is a decompensated cirrhosis, uncontrolled alcohol use, or uncontrolled thyroid disease. We should stay away from using resmetirom. We should monitor for gallstones in these patients that may cause complications, and we should monitor liver enzymes on resmetirom. So to summarize, we all know it's a global problem. There is an FDA approved agent, that is resmetirom. Other agent is semaglutide now, which has been recently approved for patients of steatohepatitis with fibrosis. It is a liver-specific agent, unlike a systemic agent, so specifically targeting liver and decreasing liver damage, also improving fibrosis, also improving dyslipidemia, LDL, and expected to improve cardiovascular mortality. There is additional lipid lowering benefit, and only the side effects are minimal. It's once daily dose and expected to be tolerated well by all patients. Thank you. So let's get together to reverse the MASH. Thank you.
Thank you very much, sir, for such a great, insightful session. We have got few questions. Can we start, sir?
Yes, sure.
Okay, okay.
So there is some question that I am able to see that can we use resmetirom in combination?
Yes,
So I
sir.
think there are no data, but there is some data of using it in combination of FGF 21. And I think it is, I personally believe that combination is the way ahead, but we need more robust data to actually use it in combination. I think off-label, a lot of people are using agents in combination. We all have used saroglitazar in combination with other agents, and we should be, but for data, we are still lacking data for added benefit for it. Can resmetirom be prescribed in F4 fibrosis? I think that approval is for F2, F3 fibrosis. We have shown studies where F4 fibrosis, it does work even in patient with CSPH and up to 70,000 platelets or above. It can be given if there is no history of decompensation, but approval is not there. It would be an off-label use. So
Okay.
who are ideal patients for resmetirom? When you have agents like saroglitazar, GLP-1, tirzepatide, FXR agonist, and so on. So I think each one has its own advantage. Now let's understand you have a obese patient. Obesity, a BMI of 35, 40, then obviously we would be preferring an agent which is likely to cause more weight loss. So there was a slide where we say that if your diabetes is a major concern, if your obesity is a major concern, or are you looking for a liver specific agent? So if your diabetes is uncontrolled and HbA1c is hovering very high, it would be preferable to add SGLT2 inhibitors as an anti-diabetic agent to have an added advantage of these agents as compared to resmetirom. Resmetirom is liver specific, irrespective, just with an elevated LDL and lean NASH. I think it is going to be the drug of choice. Saroglitazar only for dyslipidemia, but saroglitazar, I think it is ease of ability and safety data. People do prefer it, but I think it is yet to be FDA approved, and to comment on its regular use in beyond dyslipidemia patients, we are not very sure.
Okay, okay.
So
So
is there any concern about long-term stimulation of thyroid pathways or any hormonal changes given the drug's THR-B selectivity? I don't think that there is any concern. It is very specific, not very significant. Any serious adverse event have been documented. What are the effects of liver enzyme? I think the liver enzymes do shoot up for some time within the first 4 weeks as per the data. For a personal experience, I would not say that I have had many. I have a few patients on resmetirom, and we have not noticed any liver enzyme elevation, but it is something which has been seen and we should be aware of.
okay. Sir, are there any long-term safety concern associated with resmetirom, or what all monitoring we should be focusing on?
I think monitoring slide was already there, where we should be monitoring the lipid profiles as well as the thyroid function. So anybody with uncontrolled thyroid disease, we should be monitoring those agents. I think for us, it is very short-term data in India availability thanks to ETRO, but there is not long-term concerns seen. Long-term efficacy also, we have to wait for it to get an answer onto it.
Okay. So basically, when the patient comes to you, so in which all conditions resmetirom should not be indicated, or we have the contraindications mentioned in the guidelines as well, but clinically how it is important? What all are the conditions?
So it is very specific indication. So anybody with just steatosis and no fibrosis, you should not be using resmetirom. Or the patient has already progressed to a decompensated cirrhosis, you should not be using resmetirom. So resmetirom has very select moderate fibrosis patients where patient has fibrosis but not developed cirrhosis, and there is a progressive disease. You need to use this agent to reverse the fibrosis. So it does benefit in F2, F3 fibrosis. And I think there would be some time where it would be recommended for F4 also. But in the current era, F2, F3 fibrosis. So we see elevated fibroscan, no clinical liver disease, and there is, besides steatosis, some fibrosis, we use resmetirom.
Okay. Okay. There is one more question, sir. How soon we can expect to see changes in liver fat content or liver parameters or NASH activity score after initiating resmetirom?
So at 12 weeks, there was one study which showed that at 12 weeks, if there is a response to resmetirom and you are able to document that MRI PDFF shows response in fat reduction at 12 weeks, then the chances of NASH resolution at 36 weeks is significant. So we expect at 12 weeks, we need to have a quarterly evaluation of this patient to see the benefit.
Okay. Okay, sir. Okay,
Yeah.
so we have finished
From
with
your
most of
side, yeah, any inputs from your side? Because, this is something which is not as easily available agent in India. We are getting it via you for a lot of our patients in this group of patients, and that also for very short period of time. So our personal experience in this agents is not as robust as the West. And whatever that we have is for a limited patients for a short duration, and majority is on the based of literature rather than
Yes, sir.
personal experience.
Yes, sir.
Disclaimer that we have to give.
Right, sir. Right. So, I guess we have finished with most of the questions, sir. I'll hand over the session to Mr. Vikrant Desai.
So, thank you so much, Dr. Parikh sir. As we draw this enlightening webinar to a close, it's my privilege to extend our heartfelt gratitude to all those who have made this event a success. Firstly, a huge thanks to our esteemed speaker, Dr. Pathik Parikh sir, one of the leading gastroenterologists and hepatologists of Ahmedabad, whose insightful presentation and thought-provoking discussions have enriched our understanding not only on resmetirom but in overall management of MASH as well. Thank you so much, sir, for this wonderful session. I would also like to express our deep appreciation to our participants, attendees for their gracious presence despite of their busy schedule on a Wednesday evening. Thank you for active participation and engaging questions. I also like to thank our entire team, our Senior Vice President, sir, our sales head, ZMs, RMs, and entire HO team, along with Hetal Goyal, IT team, and our product management team. The entire scientific session was really insightful. Thank you so much. You leave us with new insights and learnings. So thank you, Dr. Pathik Parikh, sir. Thank you. Thank you so much, sir.